Well, first off, I want to thank the people from Snowasis BioXclude for having me here today. I really do appreciate the opportunity to be part of this, and I got to be honest with you, it's like I feel like I'm shooting free throws after like Larry Bird, Magic Johnson, and these are all hard acts to follow, to be quite honest with you. But I really am appreciative of the opportunity, and I also appreciate the people who are here today. I really think you guys are going to hear, you've heard, and hopefully are going to hear some pretty special stuff. Now, with that being said, I want to tell you a little bit about me. My name is Bob Miller. I'm a private practice periodontist. I practice in a place called Plantation, Florida, which is just west of Fort Lauderdale. I graduated the Boston University perio program back in 1986, and I've been in private practice since August 1st, 1986. So I'm coming from, probably a perspective not unlike most of you in the audience. I am on faculty both at the University of Florida and Boston University, involved in teaching in those places, and I'm also proud to say I'm an ITI fellow. Now, typically, when I begin my presentations, I like to start with a quote that I think is relevant to the topic that I'm presenting on. I think most of you have heard of Warren Buffett, and one day he said something to the effect that someone is sitting in the shade today because someone planted a tree a long time ago. Now, truth be told, that's relevant to quite a number of different things, but I think it really has particular relevance to the concept of implant dentistry and guided bone regeneration. In other words, if you really look back and look at the original principles that were put forth back in the late 1970s, early 1980s, middle 1980s, and 1990s, a lot of the principles that we're using today were sort of demonstrated and sort of forced into our minds, so to speak, way back then. And what have we done since the middle 1980s, 1990s? Well, basically what we've done is yes, for sure, we've improved upon the techniques, but to a large extent, what we've done is improved upon the biomaterials. So I really do feel that this quote has a lot of relevance to what the overall theme of actually this AO meeting, and also what I'm trying to present to you today, because I really do believe that biomaterials can and do make a difference. Now, the title of my presentation is Facts, Fantasy, and Frustrations of Simultaneous Implant Placement and Guided Bone Regeneration. And basically what I'm going to try to do is, again, show you how biomaterials can and do make a difference, okay? And also in terms of long-term success, because I'm going to show you some long-term success, and I'm also going to show you how I believe that it increases patient acceptance. Now, typically what I do is I break my presentations up into a couple of small parts. The first thing that I'm going to do is I'm going to show you a retrospective. And it's really important to understand where we came from and how we got to where we are today with these principles that I was talking about from way back when. Okay? And I'm also going to show you how I really believe that successful guided bone regeneration is essential to all our practices. I truly believe that. And then what I'm going to do is I'm going to introduce a bone defect classification scheme. And I'm hopefully going to show you how you can look at both extraction sockets as well as bone defects and determine whether or not it's appropriate for simultaneous implant placement and guided bone regeneration, or should you be considering a staged approach. Now, throughout the presentation, what I'm going to do is I'm going to sort of sprinkle in my own personal cases. I'm going to show you how I'm using BioXclude successfully and predictably in my practice. Now, like I said, I graduated the BU program back in 1986. And back then, there really was no implant education, okay? And clearly there was no such thing as guided bone regeneration. Actually, what I did was I took the Bronnemar course. I was one of the first periodontists to take the Bronnemar course back in 1987. And I really, truly, and honestly feel blessed to be part of this quote-unquote wave of implant dentistry over the last 30, 40 years. And truth be told, I feel blessed from the standpoint that I've actually seen a lot of trends in implant dentistry kind of come and go. And I sort of feel that it gives me a unique perspective on implant dentistry and guided bone regeneration. So again, I feel very blessed in those regards. Now, when I look back, I was in my dental school at the time, and there was an article that came out back in 1981. It was by the Swedish group, and it was a 15-year retrospective on success in with dental implants. And truthfully, it was the first article of its kind in a refereed journal. And it really made a lot of people sort of stand up and notice implant dentistry. In other words, it became something that not just the cowboys of our profession did, but it was actually brought it into mainstream. And it was really very impactful, to say the least. A couple of years later, the implants became provisionally approved in teaching institutions and this and that. And ultimately, a book was published called Tissue Integrated Prosthesis, and that was published in about 1985. And this was the quote-unquote Bible of implant dentistry. And there was a couple of very interesting things in the book. But one of the things that sort of stands out to me was the discussion of the initial protocol. Okay? Now, the initial protocol, according to Dr. Bronnemar, was basically you remove your hopeless teeth. Okay? You debride the area thoroughly, removing any infection, soft tissue remnants, and things like that. And remember, back then there was no such thing as GBR. So what did we do? We let it heal for 1 year. Let it heal for 1 year. Okay? Soft and hard tissue maturation. Then, and only then, you could place your dental implants. So we placed implants, we'd bury our implants in the mandible. It was a 6-month period for osseointegration. In the maxilla, it was 8 months. And so if you sit there and start doing the arithmetic, it was anywhere from 18 to 20 months before you uncover your implants. Okay? So if you think about it, that was approximately a 2-year treatment plan. Now, I don't know about you, but I remember when I was sitting with my patients and describing this process, and I would say, they'd look at me like I have 2 heads. They'd say to me, Dr. Miller, I don't even buy green bananas. I'm not considering this kind. People want immediacy. They want fast food, fast cars. They want everything right away. And that's just how society is. And so as much as I talk about it, it really wasn't widely accepted in the true sense of the word. Now, I believe that the true paradigm shift came back in about 1989. This is an article by Dr. Richard Lazzara in the International Journal of Periodontics and Restorative Dentistry, and this is a gentleman who sort of started 3i, and he's had a number of major contributions to dentistry and implant dentistry in particular, the whole concept of platform switching, a number of different things. But this article, I truly believed, fueled the wide acceptance of dental implants and popularized it. And essentially what he showed us was that you can actually place implants into extraction sockets and have success. Now, why was that successful? Well, I think because, number one, it cut down on the number of surgeries, and number two, it cut down treatment time. Okay? And that made it a lot more palatable for the general population. I truly believe that. And so over time, what happened in the mid-1990s, we talked about gap-type lesions. Anything over 2 millimeters, we'd put a little freeze-dried bone collagen membrane on top of that. And that became the treatment of choice over a short period of time. And again, that fueled the acceptance of dental implants into our treatment planning. Now, another article, which I also think is really, really interesting, came with Dr. Boozer, H.P. Weber, the Swiss group. And what they estimated was that no less than 40% of all osseointegrated implants require some form of GBR as part of their rehabilitation. Okay? Now, if you all sit and look at your own personal practices, or when I sit and look at mine, well, what do I see? Well, yeah, sure, I put a bunch of dental implants in on a yearly basis. But what do I do most of my day? I take patients who are marginal candidates for dental implants and hopefully make them good candidates for dental implants. That's what I do. So what do I do on a daily basis? Yeah, I place implants, but at the same time, I do a lot of GBR. And I kind of laughingly say that I'm not just a periodontist, I'm a kind of a GBRologist, if you will. And I believe that if you're going to be a successful surgeon, implant surgeon, you have to be a better guy who grows bone, a GBRologist. Okay? And I truly believe that that's what differentiates you in the community in terms of how successful and predictable you are with your dental implants. Without successful GBR, you're not going to have successful dental implants. It's really, really that simple. Okay? So this is the typical case in my practice. Okay? I'll get a patient coming in, especially these days with COVID. Patients have been putting off their dentistry, and they come in with broken teeth. Anyway, we extract the tooth, we place a dental implant, small dehiscence type lesion, place some freeze-dried bone. I'm not unlike these guys. Borg and Mealy's article on the min-D-min 70-30, 80-20 min-D-min mixture. That's what I'm doing in my practice. Place some freeze-dried bone, place the amnion-chorion membrane on top of it, the BioXclude. This happens to be BioCover, to be quite honest with you. And then we get a situation like this where we got a really nice little knuckle of bone there. And that's what I do. Okay? And these are some of the post-op x-rays. We did that back in 2012. These are some x-rays, 2013, 2014, 2019, 2017, and here's your 10-year x-ray in 2022, 10-year post-op, okay? And that's what I call predictable long-term success. Now, when I think about the factors that make things successful, what are the factors that influence clinical success? And I think about this on a day-in, day-out basis when I'm treatment planning my patients. And this is a diagram that you find in the ITI Treatment Guide, volume number 1. This was put together by Danny Boozer, Will Martin, Dean Morton, a bunch of them. And what they did is they boiled down the 4 factors which determine whether or not you're going to be successful to the patient, the clinician, the treatment approach that you use, and the biomaterials that you choose. And it's an interplay between these 4 factors which is going to determine whether or not you're going to be successful. Now, all patients are not created equal. I think most of us would agree to that. Basically, they have different dental risk factors: susceptibility to periodontal disease, susceptibility to caries, occlusal risk factors, bruxers, clenchers, grinders. Let's face it, patients don't lose their teeth because they're good dental patients. It's really quite the opposite. Okay? Medical risk factors. Are they taking bisphosphonate? We just heard a wonderful lecture on that. Are they an uncontrolled diabetic? Are they a smoker? The jury's out, no question about it. If you're a smoker, you're going to have a diminished success rate, not only with dental implants, but your yield when it comes to GBR. All right? Anatomic risk factors. I had a patient who needed a crown lengthening. I still do crown lengthening, by the way. Anybody want to refer a patient to me? But I still do crown. Anyway, bottom line is they needed a crown lengthening on a lower second molar. The tooth is embedded in the ramus of the mandible, the high floor of the mouth, horizontal external oblique ridge, and they can only open up the size of an Oreo cookie. Okay? That patient's going to have a completely different experience than someone who can open up like a crocodile. No question about it. Now, what about we as clinicians? We bring different things to the table. We have different experience level, skill level, judgment. The truth is that why are we here? We're all trying to become better clinicians. That's why I'm here. The treatment approach. There are even some procedures that the most skilled clinicians have trouble delivering predictability, and clearly that's going to influence clinical success. But the most, I think, interesting of the four factors is the biomaterials that you choose. And I truly believe that there are biomaterials that work better in my hands than others. And I truly believe that there are biomaterials that are more appropriate for certain situations than others. But the interesting part about biomaterials is the only thing that you have complete control over. You choose your biomaterials. Okay? You can't pick the patients coming into the practice. You can elect not to treat them. Okay? Your skill level is your skill level. Your experience level is your experience level. And truly, all of us are here trying to become better clinicians. Our treatment approach, yes, sometimes we are locked into certain situations, but I truly believe biomaterials make a difference. Now, here's what I want to do. I want to show you a quick case that I hopefully demonstrates this. This is a 4-unit bridge, 17 to 20. Both the anterior and posterior abutments are completely washed out. Obviously, the two teeth are no longer viable, salvageable. So our treatment plan here was to extract tooth number 17 and number 20 and basically place implants in position number 18 and number 20. So we open up the area, extract the teeth, and what do we see? Well, what we see is we've got a pretty thin ridge there. Okay, just anterior to position number 17, 18 area. We have a significant loss of buccal plate in position number 20, but we still would like to place our dental implants. Now, I'm able to place these two implants in a restoratively driven fashion. I knew I had a very large loss of buccal plate on number 20, so I made my cortical perforations in advance of putting my dental implant in. And I continue to place my cortical perforations, and I use the same thing. I use a min-D-min mixture of bone, place that on top, and then on top of that, I use my amnion-chorion membrane. And again, I'm not going to, review the fact that it's extremely, extremely easy to use. I've worked it out where the membrane will either adhere really nicely with the patient's own blood, or we can use some saline on top of it. But it's an extremely easy to use product. The beauty of it is you don't have to tack it down. You don't have to, suture it down, which I do quite frequently with my other membranes. But the membrane kind of sucks right down into position. I use a tension-free primary closure. I place a couple of horizontal mattress sutures, a couple of simple interrupted, and then I send them home. The next step is we allow 3 to 4, sometimes 5 months for post-operative healing, hard and soft tissue maturation. And what do we wind up with? A beautiful buccal plate. Okay? Very straightforward, very, very simple to use. Okay? So, take a look. Let's take a look a little bit further back. You can see the ridge is thickened out really beautifully in the posterior, in the saddle area, as well as the most distal implant. This is a CT section showing that we were able to really regenerate the buccal plate very, very, very nicely. And then we take a cross section a little bit anterior to the most distal implant, and you can see where we're able to regenerate a significant amount of bone. And again, no magic, no voodoo. Just very straightforward, predictable dentistry. Here's our final restoration. Here's a 2021. I know periodontists and oral surgeons like to look at x-rays, so I always include the x-rays on these things. And that's our 2021. Now, once we're in the midst of this, okay, we're in the chair, we're looking at our patients, we have a couple of choices to make. And one of the first choices that we have to make is whether we're going to do this in a simultaneous fashion, with or without its extraction or ridge defect, immediate placement of the implant, or we're going to consider a staged approach. And that's the first thing that we have to decide. And I got to be quite honest with you. The first thing that I look at is if this is a restoratively driven procedure. Can my restorative doc, I don't restore my own implants, can my restorative doc restore this in a predictable fashion? If they can't, we're doing this as a staged approach. I don't care if whatever else is going on, we're doing it in a staged approach. Now, someone once said that implant treatment is surgically driven. I suppose it is, because surgeons place the implants, okay? And so I assume that it is surgically driven, but it must be prosthetically guided. That is very, very important. Now, there's a number of things that I look at in terms of site evaluation, whether I'm going to do this in a single procedure or multiple procedures. And one of the things is, obviously, I need to attain good initial stability. Not just of my dental implants, but I also have to have stability of my graft. Okay? Very, very, very important. But the other thing that I think is equally as important is the soft tissue and bone quality, quantity, and morphology. Okay? If our soft tissue isn't right, we have to do this in a staged approach. And here's what I want to do. I want to show you a real quick case here, interesting case. This is a young girl who comes to me from Mexico, and she, I think most of you can see that there's a pretty significant recession-type lesion here on the labial aspect of the cuspid. We have a lack of keratinized tissue, okay? If you look at the radiographs, you can see we got a whole host of problems. No buccal plate, a lot of problems going on here. So a little red flag kind of comes up. So what do I do? What's my next step? My next step here is to extract the cuspid and allow the area to heal for 6 to 8 weeks. Why am I doing that? Because I want to regenerate that keratinized tissue. If I don't regenerate that keratinized tissue, what's going to happen? I'm going to have to hike up that buccal flap, if you will, reducing the depth of the vestibule, and I introduce a whole new set of problems to the situation. So what I'll do is I'll let this start healing for me and reforming keratinized tissue. Reflective flap. At this point, I'm able to place my implant again within the confines of the bony envelope. Okay, I've got good initial stability of my implant. Yes, I have a significant dehiscence type lesion on the buccal aspect. I graft that with my freeze-dried bone. I place my BioXclude membrane on top of that. If your membrane's too big, you can fold it over on one another. It's a very, 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 very easy to use. Once you've used it once or twice, it becomes extremely easy to use. And yes, I'm able to recreate or regenerate that buccal plate. And then ultimately we restore it. You can see I have a nice zone of keratinized tissue. We've got a nice thick buccal plate. Here's our pre-op, here's our post-op 2020 and 2022, or 2021. I just saw it the other day. I should add in the 2022 x-ray. But what do we have here? We've regenerated that buccal plate. And I'm very confident that that's a home run. That implant should last pretty nicely. Now, what are the advantages? What are the advantages? I've yet to meet one patient that comes in to me and says, Dr. Miller, I'd much prefer multiple procedures. I'd really like to do this in like 3 or 4 steps. Most people will say to you, yeah, if you can place the implant simultaneously and still do a good job, why not? Okay? Why? Because it reduces treatment time. Okay? And ultimately you get your patient acceptance. Now the other thing to think about, which a lot of us don't like to really talk about, is it's a win-win situation, not just for the patient, but for the surgeon. Why? Because we're performing more procedures in that allotted time. So our chairside productivity increases. Okay? So there's a number of different moving parts to this. And so in my mind, obviously I'm not going to do something that's going to jeopardize the predictability or long-term success. But at the same time, I would like to make the patient happy. And if you think about it, where is implant dentistry going? It's going towards immediate load, immediate placement, immediate provisionalization. That's why all these companies, ClearChoice, and all of them are very, very, very successful because of the concept of immediacy. I guarantee if you start walking around here, there's at least 3, 4, 5 people who are talking about immediacy. Immediate load, immediate provisionalization, because that's just how our society is. So it's all about patient acceptance. Now, there's a number of things that can occur in the course of a day in our practices. Root fracture, tooth decay, advanced periodontal disease. And all these things are sort of coming to light because of COVID. A lot of patients have taken a 1 or 2 year hiatus from dentistry, so everybody's kind of coming in and their hair's on fire and they got to be seen immediately because they're in pain. That's just how my practice is working out. I had a patient not too long ago had a root fracture. Crown loosened up on tooth number 8. The post actually formed a little bit of what we might consider a root fracture. There was a vertical root fracture. I don't know if you can see that in there, but we have a nice root fracture in here. And so clearly the treatment of choice here is to take the tooth out and place a dental implant. Typically in these scenarios, I'll go in and take a little chisel and finish the fracture, take it out in a couple of pieces. If you look real closely here, you can see the tissue is starting to fold in on us. So we pretty much know we've either got a very thin buccal plate or we have a small dehiscence type lesion associated with this. So I'll open up the area, and yes, you can see just how thin that buccal plate is. I start playing around with my twist drills. Can I place this implant in a restoratively driven fashion? The answer is yes. I can get good initial stability. So I go ahead and wind up placing my implant. Again, you can see it's in a restoratively driven situation. We've got a small gap type lesion. So this is something that I'll go ahead and graft, place my BioXclude membrane on top of that. In this case, I used the ceramic abutment. And it's really interesting. Soft tissue likes metal, titanium, but it loves ceramic. And I just was so blown away with the soft tissue healing in this particular case. You can see some really, really nice soft tissue at this point. Wound up getting it restored. And I actually think the implant crown probably looks better than the natural tooth at this point. But the beauty of it is we were able to match the gingival margins and create what I consider a relatively aesthetic result with this case. So here's our final radiograph back in 2021. Now I'm anxious to show you a couple of more cases here. We get some residual roots coming in these days. I'm sure you guys too. We have a situation here where we have a lower molar, which clearly has outlived its usefulness, and these two roots should be extracted, and then maybe we can consider putting a dental implant in. Take an occlusal view. You can see the two roots clearly. These are something that we're going to take out. So I remove the two residual roots, and I'm looking at that intraradicular bone, and I'm saying to myself, this is probably not something that I want to do an immediate in. So I wound up grafting it, my BioXclude membrane on top of that. We talked about the antimicrobial factors, and this is not a problem to leave open, at least in my mind. Okay? Wound up letting that heal. You can see some really, really nice new bone there, and very easy to place our implant. And again, some nice soft tissue healing. I'm a big fan of tissue level implants, and that goes on to get restored quite nicely as well. I have a whole article that I was lucky enough to get published in the International Journal of Periodontics and Restorative Dentistry, which I believe is one of the AO journals now, that if you're a member of AO, you get these articles. This appeared last fall, and it goes into a little more depth, the concept of a two-stage implant placement. And I urge you, if you have this journal at home, to kind of take a look at it and read it. Here's another case, another lower molar. You can see that bone is a little thicker. And if you look real closely at the extraction, you can see how the roots kind of flare open. And in this case, I decided that I'm going to try to place this implant immediately. I used my VersaBurrs, my DensiBurrs, or whatever, osteodensification. And I was able to put my implant in and get some good initial stability in this case. I don't do this very often, to be quite honest with you, but this is a case that I did. Implants in with good initial stability, grafted it, placed a couple of 8mm square BioXcludes, folded it in on itself, and so I have some BioXclude running around in this case also. And then what I opted to do, which I also don't often do very often, is I went for primer. Here's the BioXclude in position. I went ahead and I closed it primarily, made some verticals and hiked up the tissue. Why I did it, not necessarily as well thought. It just was a gut feeling that I probably should cover it over. Cover it over, the implant ultimately gets restored, and here's our final X-ray. And again, for the patient, they were ecstatic that I could do this for them. They were ecstatic. You know, I'm a hero in their eyes. Wow, you could do that? That's great. And you know what? At least in Florida, we hear it once a day about, you know, I know this place, Clear Choice, and they do da-da-da-da. You know, and for us to be able to provide this is also a win-win situation. Now, we talk about prosthetically guided. Okay. And I want to show you something that I think is also another fairly interesting case. This is a 24-year-old boy. Graduated college a year or two prior. He has a congenitally missing lateral incisor, and he's making a few bucks, and he wants this thing restored. I look at that, and I'll be honest with you, with my X-ray vision, I'm looking at that and thinking, wow, that should be a pretty straightforward procedure. Yeah, there may be a little bit of a concavity associated with that, but I feel I can probably fix that pretty easily. Anyway, I take a Cbct, and this is an axial slice, and you can see that we do have some form of concavity associated with the labial aspect of that position number 7. Then, once we take a look at the volume rendering, you can see, and another slice, you can see the bone really thins out here. Really, really thins out. And looking at, like I said, the volume rendering, you can see a significant concavity associated with that. Okay? So the next step in my mind is to, I tell the patient, listen, there's an outside chance that I can't place this immediately. but let me see what we can do once we're inside there. Well, I go ahead, I open up the area, and you can see that's the axial slice that you probably saw initially with that CBCT. But then, when you look at the buccal aspect, we have a very, very, very significant concavity here. So the next step, and we've done, some of the other presenters alluded to the fact that we've got to place this implant in a three-dimensional, restoratively driven fashion. Now, not only from a buccal lingual standpoint, our implant positioning is important, not just mesial distally, but also apical occlusally. And it's almost more important than buccolingually, because if you don't place your implants deep enough, you're not going to have room for your restorative abutment and your restoration. So that becomes extremely important. And someone else said that, yes, you want to have your implants at least 3 millimeters apical to the adjacent CEJs. So here's a case where we're going to take some of that bone away. I see that once I perform my osteotomy, by the way, this is a 2.9 millimeter diameter implant. That's a Straumann 2.9. I wind up with a significant dehiscence lesion. I have my significant dehiscence lesion here, and what I do is I do some cortical perforations with a quarter-round burr prior to putting my implants in, because I tend not to like to nick my implants as I'm before they're in position. You can see we wind up with a fairly significant dehiscence lesion here, but this is well within the confines of the bony envelope. All right. Now, the next step here is to consider some sort of a graft. Now, I felt I had enough implant in native bone that I wanted to have somewhat of a contour graft associated with it. And I wound up using a xenograft here. And this particular xenograft has a really impressive amount of hydrophilicity. Okay? Meaning, hydrophilicity means it tracks blood and blood proteins. Most xenografts are hydrophilic in nature, whereas freeze-dried allograft is hydrophobic, which is why you want to hydrate your allografts for at least 15 minutes prior to using it. Okay? So this is a very, very hydrophilic xenograft, which I kind of like. And then what I did was I used, not to borrow some of the terms of my previous lecturers, but I used the BioXclude as a biologic in this situation, which is, there's nothing wrong with that. I already told them I'm going to borrow some of their terms, but it's a biologic. So I placed my BioXclude on top of that, and then what I did was I placed a porcine pericardium membrane on top of that. Now, the reason why I use a porcine pericardium membrane, it has to do with the resorption time. Porcine pericardium tends to retain its barrier function anywhere from 3 to 6 months. And when I use a xenograft, okay, xenografts also take a long time to turn over. And a bunch of guys at the University of Bern contend that xenograft actually never goes away. So I tend to like to retain that barrier function for as long as possible, as much as 3 to 6 months. Why? Because you'll get particles of the xenograft kind of slipping through because they're not yet incorporated in the new bone. All right. So place my xenograft, place my BioXclude. There's my porcine pericardium membrane in position. Used a couple of non-resorbable polypropylene sutures. That's a 1 week post-op, and we allow things to heal. And this was literally about 5 months, 6 months after implant placement. This is the day of insertion of the prosthesis. Here's our before and after CBCT. Some reasonable buccal plate, and this is an 18-month post-op with that implant in position. Okay? So again, I think it's a fairly good result, I think it's a great service for the patient, and again, win-win-win for most of us. Now, what I want to do is I want to switch gears a little bit here. I want to talk about this bone defect classification. Originally, believe it or not, I saw this bone defect classification in Lang and Lindy's textbook. Okay? And then I did a little research. It's actually Benich and Hammerly, Christoph Hammerly in University of Zurich, who kind of proposed it. And basically what they've done is they've broken it down into from 0 to 5 in terms of bone defect classification. Basically a class 0, well, that's where you have almost too much bone. Got to remove some of that bone to make room for your restorative abutment and crown. Class 1, well, that's a small dehiscence lesion or maybe a gap type lesion. Class 2, that's a little bit larger dehiscence lesion, but basically, as long as it's in a restoratively driven fashion, you should be able to do this simultaneously. Class 0, 1, and 2. Class 3, 4, and 5, a little bit different. These are situations where you may or may not consider doing this in a staged approach. So taking a look at a class 3 lesion, okay, that's a little bit larger defect. And you may or may not consider, like I said, doing this in a staged approach, particularly if you cannot place the implant into within the bony envelope. Class 4, Class 5, those are also more difficult to consider placing immediately as well. All right, those are situations where you may not consider it. But again, class 4 lesion, that's where you have kind of thread exposure possibly as far as to the apex of the extraction socket. Class 5 lesion, well, that's when you have actually implants outside of the bony envelope. And again, those are situations that are a little more tricky. Now, I want to show you a class 0. We talked about this kind of briefly. These are situations where you want to remove a little bit of bone, make sure you have 3 millimeters of distance between your CEJ and the head of the implant. So here's a case, basically I think this is the only case I've ever done that did not need guided bone regeneration. So I like to show it. And again, a fairly aesthetic result as a result of that. Class 1 defect. Little bit different. This is a situation where, well, actually, this is a patient, a young guy, 24 years old, had some trauma, has some internal and external root resorption on tooth number 8, and so we want to take this tooth out. You can see he had a little bit of apical pathology associated with it. But again, when I palpated the buccal plate, fairly intact, maybe a little bit thin. So this is a situation, as long as I can place my implant in a restoratively driven fashion, not perforating the apex or the buccal place apically, have a small gap type lesion, grafted it with a little freeze-dried bone, BioXclude membrane on top of that. Very, very, very predictable. You allowed the area to heal, and we got some really nice soft tissue response as a result of that, and then ultimately this is his restoration. And again, a fairly reasonable result aesthetically, maybe not the best smile in the world, but this gentleman was really, really happy. And again, these are the cases that keep most of us up at night when they have this, when they display all this gingiva. Here's our radiograph, external root resorption, implant placement, and this is the 2020, and 2022 radiographs of the case. Now, what is this? Try backing up again. Oh my God. Excuse me. We don't want to see that. Super. So, here's our 2022. Oh, shoot. Okay, so here's our class 1, 2, and 3. This is a class 2 defect, a little bit larger dehiscence type lesion. We were able to place, like I said, the implant in the buccal within the confines of the bony envelope. freeze-dried bone, BioXclude membrane, and we wind up with a really, really nice knuckle of bone here. And again, very straightforward, following the principles of number 1, restoratively driven implant placement, number 2, okay, within the confines of the bony envelope, and number 3, good, solid GBR. Okay, here's our before, here's our after, and nice bleedy bone here. And this is 2017, 2019, 2021, and I just don't have the 2022 x-rays. So again, that's a 5-year post-op and still going strong. Can't argue that. Now, let's take a look at Class 5 and Class 6. Kind of anxious to show you these cases. A little bit larger defect here. We have some external resorption, completely blown out buccal plate, implant placed again within the confines of the bony envelope, a lot of thread exposure here, freeze-dried bone. We have a BioXclude membrane on top of that. Here's where we started. Here's where we ended. Okay. Nice to sometimes play, where's the implant? Class 5, Class 4. This is a case that, quite honestly, would I consider doing this in a 2-stage approach? The answer is yes, because it's almost outside of that bony envelope. Grafted, before and after. Nice, healthy bone. Now, the last one here, I like showing this case because it shows side by side using different techniques. This is a woman who came to me. She had some very, very significant trauma. She had a vasovagal response where she fell in the evening and smashed her face on the bathroom sink. Displaced the teeth. Huge issue. Huge, huge issue. She couldn't close her mouth. It was a real problem. Broke the bone. So the treatment plan here was to go up, probably take out tooth number 8 and 9 because they were hyper mobile. Here's our radiographs. Fortunately, none of the teeth fractured, but the bone fractured. So tooth number 8 and 9 came out. Then we took a look at position number 7. Position number 7 had the buccal plate. Basically, we could remove with some pliers. And then when I started thinking about it, would I really want to restore implants in position number 8 and 9? Because it's probably one of the more difficult things that we do. But if I take out tooth number 7, I can place implants in 7 and 9 and hopefully have a more aesthetic result. So, here's where we're at. Virtually no buccal plate. Start playing around with my twist drills to see if implant placement is possible in a simultaneous procedure. And I determined, yes, that is a possibility, but the implant in position number 9 is clearly going to be outside of the bony envelope at this point. So what I decide to do, I've taught the allograft bone ring course for about 3, 4, 5 years with Dr. Giesenhagen in Germany. And for those of you who are not familiar with the allograft bone ring, basically what it is a machine cylinder of bone. It comes in either 6 or 7 millimeter diameter. And the donut hole within the allograft bone ring, the 6 millimeter diameter bone ring will accommodate a 3.3 millimeter diameter implant. The 7 millimeter diameter bone ring will accommodate a 4.1 millimeter diameter implant, or a 3.3, depending on which one you order. They're 10 millimeters long, and what you do is you create an osteotomy using, first off, a trephine. you use a trephine that corresponds to either a 6 or 7 millimeter diameter bone ring. You start your osteotomy with the trephine. You have a guide pin that will hopefully guide you and make sure you place the implants where you want to place them. And then you remove the bone chips that are created by the osteotomy with the trephine. You save those for your graft. And then you go in with something called a planator, which flattens the floor of the osteotomy. The floor is flattened, and then when you place your bone ring into this bone ring osteotomy, it's fairly stable. Why? Because it corresponds to the diameter of the trephine. All right? Then I make sure I'm going in straight. That's here you can see this is the planator, this is the trephine, and this is the direction indicator. And the apical threads of your dental implant will stabilize the bone ring implant complex plus the snug fit of the bone ring within the bone ring osteotomy. So basically what happens is that bone ring implant complex becomes very stable. And that is important in terms of creating a successful implant as well as GBR. Now, the other side, I decided that I'm going to do this more or less conventionally. So I have some exposed threads here, and I decide I'm going to graft this and use a BioXclude membrane on top of that. So went ahead, grafted the implant, placed my BioXclude membrane, cover my implant in position number 7, and then I follow the clinical protocol for the allograft ring, which is placing xenograft on top of that and a collagen membrane, which we suture into position. Okay? And close things over. This is a tension-free primary closure, again with some horizontal mattress suturing. And at this point, the patient goes back to their restorative dentist in Hollywood, which is just south of me in Florida. And actually, this is a Philadelphia patient, to be quite honest with you. She was visiting or spending time in rented a place or whatever the story was. And this is how she goes back to Philadelphia. Got a couple of nice x-rays. This is January 17th. January 7th we did it. And she left back for Philadelphia in March. And I take my x-rays and everything looks fairly decent. Well, this is how she returns. Wasn't necessarily ecstatic with the aesthetic result, but that's how it is. And you can see that our 2019 x-ray, we get some really nice regeneration there around those two implants. This is our 2019, 2021 radiographs, and this is the Cbct depicting a really nice buccal plate, not just with my allograft ring, but also doing this case conventionally, and a lot, to be honest with you, a lot more simply with the BioXclude. This is how she started, that's how she finished, and this is her final smile. And again, a pretty happy woman at this point, considering where she came from. Now, I'm going to end with one more case, okay? And I think you guys will kind of get a kick out of this because not a lot of people have seen this case before, these types of things done with BioXclude. This is a Wilkadontix case. For those of you who are not familiar with Wilkadontix, it's a surgically assisted or surgically facilitated orthodontics, and we initially, when we first started doing it, when I took the Wilco course, we were doing it as to make orthodontics proceed more quickly. That's why we were doing it. But in many situations, we're doing it in these ridge expansion cases where we're worried about our buccal plates. So this is a case where obviously you can see that the lower left first bicuspid obviously has been squeezed out. That tooth has to go. And what they were going to do is they were going to expand and get rid of the crowding in the lower anterior. This was the Invisalign plan. You can see we take out number 21, and there was a certain amount of expansion associated with it. This is where we started. And typically, you can see when I take my Cbct, you can see very little, if any, buccal plate associated with that. So clearly, that's something we wanted to consider. I do my Wilkadontix pretty much, the tried and true way, the way I was taught from the Wilco brothers. I use a quarter round burr to create my cortical perforations. This case, I use some xenograft. I wanted to see how it worked with xenograft, and this is my BioXclude membrane on top of the xenograft. I actually had to use two pieces because it was such a large area. Closed over, this is the suturing, and then this is, she initiates her orthodontic therapy, and this is the final. You can see they were able to accomplish exactly what they set out to do with their Invisalign treatment. And this is the final picture. And you can see, if you look real closely here, you can see that actually some of the xenograft, because I did not use porcine pericardium membrane on top of that, you can see the particles of xenograft kind of leaching through there. Here's our new buccal plate. You can see that this tissue, I think, is fairly thick here, and I think over a period of time that's going to probably turn into keratinized tissue. And I think that if you look at the before and the after, I think we've got a pretty reasonable result here. And I think this is kind of one of the more novel uses for BioXclude, and I think it's something worth considering. Anyway, I want to thank everybody for your attention, and obviously you can email me at drmiller@webperio.com if there's any questions. I'd be happy to answer any and all of your questions, and that's where it's at. Anyway, thank you. Any questions, or are we ready for lunch? I'm ready to go home. I'm 3 hours different here. Yeah. All right.
You don't use the sticky bones anymore, or you have not?
That's a really good question. The answer is yes, I did the other day. I do on certain occasions. I do on certain occasions. I do. Because I was kind of brought up doing it. And I probably wouldn't. I probably would be more apt to use it when I need a larger quantity. And I don't use it nearly as much as I did 15, 20 years ago. I mean, I used to use it regularly prior to BioXclude. I was using it regularly. Now it's a rare bird when I use it. And I teach at University of Florida, and that was one of the things that so the residents really wanted to do it. And I actually happened to use it like 2 weeks ago. Yeah. But I can tell you, since I've been using BioXclude, I've cut down dramatically with that. I also used to use Emdogain in my grafts, and I stopped using that because I found BioXclude to be more successful. I wrote an article also on about 10 or 15 years ago on using Emdogain in my freeze-dried bone grafts for GBR, because I like the concept of having VEGF, vascular endothelial growth factor. I think blood is the most important thing in a blood clot. Singularly is the most important thing you can have in a graft. Oh yeah, I use it. I wasn't going to get into it, but I routinely put it, even if I don't perforate the membrane. I will use BioXclude in my grafts.
You will push it through the partiality.
Yep. I didn't want to do any overlap, but the truth is is that, yes, I do. The first time I used it, somebody, I think Rob, told me that, oh, Bob, why don't you use it in your grafts when you tear it? And I says, well, periodontists, we don't tear membranes. But the truth is every now and then I have to admit to it. Every now and then. We're not recording this part, are we? Well, absolute pleasure. Thank you for coming.